Hello and welcome to this special webcast event as we bring four industry thought leaders to the table to discuss the topic of telemedicine. I'm Carol Flagg of Answers Media Network and Healthcare Now Radio. Thanks for joining us today as our all-star lineup help you make sense of the current telemedicine landscape, offer valuable insights, and consider best practices for telemedicine adoption. The panel will also forecast where telemedicine is headed in the coming year. A link to the recording of this discussion will be sent out to you within 24 hours. Also, this webcast is best viewed full screen on your computers or laptops. Today's webinar is sponsored by GlobalMed. GlobalMed powers the world's largest, most advanced virtual care programs with over 15 million consults delivered in 55 countries. The company designs, manufactures, and deploys fully integrated software and hardware solutions that remove the barriers of technology from the business of patient care. The company is honored to be the telehealth provider to the Department of Veteran Affairs, Defense Health Agency, and the White House. And now to introduce our moderator and panelists. Our moderator is no stranger. Matt Fisher is a partner in the law firm of Mark O'Connell, and Matt focuses his practice on health law and all areas of corporate transactions, including advising clients on complying with requirements of HIPAA, the Stark Law, the Anti-Kickback Statute, and other regulations in the context of daily operations, contractual arrangements, and relationships. He is a co-chair of the American Bar Association Health Law Section's Distant Learning Committee and the vice chair of both the Emerging Issues in Health Law Conference Planning Committee and the Marketing Committee. Matt also hosts Healthcare du Jour, a radio and podcast show that airs on our own Healthcare Now Radio. Our panelists today include Leslie Kriegstein, the Vice President of Congressional Affairs at the College of Healthcare Information Management Executives, or CHIME. Leslie oversees CHIME's congressional advocacy engagement efforts, which are focused on the effective use of information management within healthcare. Leslie's interest and expertise in health policy has only deepened since her time as a congressional staffer, concentrating principally on health information technology and informatics issues. Prior to joining CHIME, first as the Director of Congressional Affairs, Leslie was a member of the Congressional Affairs team at HIMSS. Speaking of HIMSS, our next panelist is Tom Leary, the Vice President, Government Relations for HIMSS, which is a global cause-based not-for-profit organization focused on better health through information and technology. Tom leads the organization's public policy initiatives and outreach to Congress and federal agencies. He also served as HIMSS Senior Director of Federal Affairs since 2003, directing HIMSS public policy activities with federal agencies, including analysis and response to federal regulatory requirements and leveraging HIMSS member subject matter experts in health IT public policy development. And rounding out our panel is Dr. Dean Smith, the Chief Medical Information Officer for GlobalMed. Dr. Smith has nearly 2 decades of telehealth, medical informatics, and clinical and operational leadership experience. He is a licensed, board-certified physician and has held positions in the U.S. State Department since 2000. From 2008 to 2018, he served as the department's senior advisor for medical informatics. In that role, he provided oversight and clinical informatics expertise to the teams responsible for creating a healthcare delivery model for State Department employees based on a secure global telehealth solution. I want to thank you all for joining us today, and of course to our moderator, Matt, and our wonderful lineup of panelists. Matt, I'm going to go on mute, and we'll see you towards the end of the conversation.
Well, welcome everybody, and Leslie, Dean, and Tom, thanks for joining today. I'm looking forward to a pretty active and robust discussion. And kind of with that introduction and with the the main topic of telehealth and telemedicine, what I'd like to do to kick it off is just to get perspectives from each of you over the topic of how virtual care or telehealth has evolved. Maybe not since the beginning of time with it, because I think that would be going back a little too far, but let's say over the past 5 or so years when it's really kind of come into the central part of discussion. And it just happens to be the order that I'm looking at it, but Leslie, would you like to kick us off?
Sure, thanks so much. Hi everyone, Leslie Kriegstein from CHIME, and our membership are the chief information officers, chief medical information officers within hospitals and health systems across the country. And, this conversation for us has very much evolved in the last 5 years. It's something that had kind of gone from a twinkle in some eyes in the private care space to, something that is fairly robustly seen, at least in small pockets across our membership, resource dependent, location dependent, reimbursement dependent, which often is more focused on state rather than federal. And then also kind of the emergence of the new players in the space too are certainly kind of moving the industry and the market forward. So we did a study just now it's almost 2 years ago with CLASS and took a look at our membership and said, who's doing telehealth? What are you doing for telehealth? What are your plans for telehealth? And I think we'll get into this more as the conversation progresses, but the number one barrier identified by our membership, which will not shock anyone on today's conversation, is the lack of reimbursement and the policy barriers. So, I think as the conversation has evolved, unfortunately, our federal partners that are making the rules and the reimbursement models aren't necessarily keeping pace with what our members, my members, would like to see and to do. But they've really thought through some unique pathways, even at cost to them, to bring telehealth services to their patients. So a lot has changed. I think more will change in the next 5 years. But I think it's been exciting, and I think we definitely need to buckle up for the future.
And Dean, would you like to jump in now?
Yeah, sure. Hi, everyone. Dean Smith, Chief Medical Information Officer at GlobalMed. First and foremost, the technology itself has really taken off in the last 5 to 6 years. Smaller, faster, better has been the catchword, if you will. And we've gone from store and forward of JPEGs and pixelated video conferencing to real-time, full spectrum healthcare. And you can virtually do everything now outside of the brick and mortar space, with the exception, of course, of invasive procedures. That stated, adoption of telemedicine, telehealth, virtual health has been relatively slow, but a steady uptick. And I've seen some studies showing 35% of hospitals using telehealth in 2010 to over 75% just a year or two ago. That stated, I guess I would finally close with a comment that telemedicine adoption rates themselves have far outpaced anything we saw with electronic health record adoption rates. And that's without any legislative carrots and sticks that we saw with meaningful use with EHR. So it tells you that the telehealth, the virtual health space is being adopted. It's slow and steady, but it hasn't had the headwinds that the EHR platforms had.
And Tom?
Sure. To echo a little bit of what the other panelists have said, we've absolutely seen an increase over the last several years. When HIMSS merged with the Continua initiative a few years ago, there was a lot of conversation around who was using the standard, and it was primarily overseas. But here in the United States, there's been a rapid uptick in telehealth and telehealth services associated with standards-based care just in the last several years, even having conversations with members of, irrespective of whether or not the government is reimbursing, and I know we'll dive into the big changes since CMS has started recognizing certain CPT codes. But even prior to CMS's starting to do that, providers have been saying telehealth is an absolutely essential part of their care delivery model. Even without reimbursement for the government, they were moving in that direction and have been moving in that direction because of the cost savings, as well as the providing more timely, more effective care to patients. So I would say just great uptick, great potential for telehealth, whether and connected care really.
So kind of picking up on the theme that I think all three of you mentioned of the the slow or maybe not as rapid adoption as maybe would be desired, despite the the observation that Dean, I think you made, that adoption has outpaced what we saw with electronic medical records, and that's, as you said, in the absence of any type of carrot or stick from the government. Something that strikes me as a conversation I was having with one of my colleagues, prior to only about an hour or so before this recording, when I was, hi everybody, sorry about that. Let me know where I cut off.
At the beginning.
At the outset of your question.
Pretty early into the conversation, into the question.
Matt, you were talking about you were having a conversation with a colleague like literally an hour before this started.
All right, great, and I apologize for that loss of connection. Hopefully we'll have a better result with technology here than would underscore maybe one of the technological challenges we can get into for telemedicine. But kind of what I was trying to get into was, talking with my colleague and telling him that I was going to be moderating a panel about telemedicine. His question to me, well, what is included in telemedicine? And I'm wondering, I think all four of us are maybe keyed into maybe more mature or more informed audiences than the general public might be. So it is a lack of awareness of what telemedicine is and what it can offer, another one of the barriers that we see to adoption. And let's go with Tom first this time around, and we'll kind of work in reverse order. The rest of you can jump in as well as you hear what Tom has to say.
Sure, and I think it's a great question to start off with, just because for a lot of our members and even folks on our team, it's why are certain things covered and why are certain things not. But I think with respect to the Medicare telehealth reimbursement, Section 1834M of the Social Security Act provides your baseline for what is covered and what isn't covered by Medicare. And early on, it was designed to provide coverage, particularly in remote areas, with initial engagement with Hawaii and Alaska as the start, and then it grew to more remote areas here in the continental U.S. But synchronous versus asynchronous is critical to the definition. So what is covered? Up until just very recently, required the law and then the regulations required a face-to-face engagement between the provider and the patient, and then you'd allowed for video-linked telehealth that could be reimbursed by Medicare. What was not covered, and what is largely not covered, is the idea of store and forward or capture the video and then forwarding it on to an additional provider. That activity has historically not been covered by Medicare as a reimbursable activity. So it's video is absolutely baseline and has been baseline. That's one of the areas that we're really trying to work on. The current an active interaction between the provider and the patient has historically been the link to what is reimbursable and what is determined to be telehealth. I know others can help me out there.
So Dean, would you like to jump in?
Yeah, no, Tom, I think you did an excellent job of characterizing the core components of virtual health: the store and forward, asynchronous, and real-time synchronous. Kind of a third offshoot that we're seeing, certainly the latest, I don't want to say buzzword, but gaining traction is remote patient monitoring, which is basically just what it sounds like, and that can be both store and forward or real time. What I think my takeaway when I talk to various groups, lay groups, I get it. They may not have very sophisticated understanding of what telemedicine is. I don't expect them to. But what has been surprising to me is when I talk to professional groups, medical groups. I just had a big meeting last week with a large multi-specialty group, and just the level of understanding there of what telehealth, virtual health is in some cases pretty rudimentary. And from that standpoint, I'm not necessarily saying it's a barrier, but it certainly underscores the fact that a lot of education needs to occur if we hope to have full adoption of the technology.
And Leslie.
So I would add to that, as we're talking to our membership about this, the future of this conversation is very much not necessarily telemedicine, telehealth, it's overall delivery of healthcare. So as our folks are looking to deliver the best care with the best outcomes, whether or not it has anything to do with Medicare reimbursement, we're seeing, facilities across the country of all resources really look at how we can meet the patient where the patient is and deliver care as quickly as possible. So of course it's the kind of the traditional settings, but it is that remote monitoring, it is the virtual care. And we've even seen CMS get a little more creative than they have been in the past with the reimbursement change last year. Not necessarily calling it telehealth, but those of us that can read between the lines of, they're thinking creatively and stretching kind of stretching things out a little bit. So I think that's where we're going to go is, all of these, whether it's remote sensors or wearables, whether it's doing things like telestroke and revisiting originating site issues. I think we do have a lot of education for probably the average patient because, you're not having that touching feeling of the doctor, which many of us are accustomed to. But at the same time, if you can avoid sitting in the waiting room with the, sneezing person next to you or, the coughing little kid with a compromised immune system, that's where you're going to start hearing a lot of conversation about the benefits. So I would also add that we're having members look at it from even an administrative improvements. So within their own institution, they're using telehealth within their four walls to do things like MedRec across departments. They're doing consults across their clinicians, things that they're not getting reimbursed for, but again, because they're seeing gains internally in productivity, it's still kind of falling under the virtual care telehealth leveraging of technology, but it may not necessarily fit the kind of traditional descriptions of care that we heard from Tom and Dean about, video or synchronous or asynchronous, et cetera. So, as this is evolving, we're going from those very narrow parameters to something that is much more inclusive and opportunistic in terms of what is best going to meet the needs of the patient.
Yeah, and I think all three of you have been hitting this, and we've danced around a little bit, but the reimbursement issue, I think it should be decently well known that reimbursement, I think as all three of you have already said, is challenging. So maybe we should walk through how some aspects of telemedicine have actually started to receive some amount of reimbursement, and then use that to pivot into remaining areas where you think it might be likely that we could see a regulatory change, or even maybe, optimistically legislative change to help with reimbursement. So I'll let one of you, I'm not sure which one of you actually will want to take the first crack at that answer. So I'll let one of you jump in now, but as I said, let's start with kind of where we've been with reimbursement. What are some of the recent changes, and then we can get into what further changes are pending.
I'll start off, and because I know my two colleagues on the panel here are far more versed in this than I am, so I'll speak probably at a fairly high level and more from a clinician standpoint, and then defer to them. But as Leslie pointed out, historically reimbursements or lack thereof has been a real barrier and impediment to adoption of virtual health, of telemedicine. Just in the last year or two, we have seen some real movement finally on the legislative front. I know Medicare Advantage plans, I believe effective January 1st, are going to start reimbursing for telehealth services, including remote patient monitoring. There's been a host of other legislative actions in the last year specific to telestroke and end-stage renal disease and opioid disorders. et cetera. So all of these have moved the ball incrementally. What we have not had is an overarching, national telehealth reimbursement plan, and I think that's clearly, at least from a clinician's perspective, is what's needed. So with that overall statement, I'll defer to my colleagues.
So, Tom, would you like to go? So I think
Sure,
you're
absolutely. So, I think from a historical perspective, it's the Congressional Budget Office has been our biggest barrier for being able to demonstrate that there's savings, and they want to see specifically within the Medicare population that it's not just a cost driver for government funding and therefore the Medicare program. So what we've been focusing on for the last several years is pulling together examples of where the telehealth resources and programs have been able to not only improve the access to care, which CBO truly anticipates, it's the how do you drive down or at least hold fast the cost of care that individuals are receiving, and so that's really the barrier that we're trying to overcome from a big comprehensive legislative perspective. But just in the last 18 months, well, a little over 18 months at this point, but a couple of pieces of legislation and then several pieces of regulation from CMS have opened up the idea of being, there are certain categories, as Dean has indicated, telestroke, early stage renal disease, and ESRD, and then telestroke are areas that have been allowed to create that a body of work that could then be presented back to CBO of greater access, cost avoidance, or at least holding down the cost of care, and actually better outcomes for the individuals. So then CBO could see for the Medicare population that there is a positive for Medicare moving further into the more telehealth coverage. And then Leslie, let me leave the most important parts from the regulatory side to you then.
Oh boy. Okay. So, as I alluded to earlier, CMS got pretty creative in some of their payment rules, starting off of last year, and they've continued into this year, adding some CPT codes and referencing HCPCS codes that are traditionally we may consider telehealth, but they are kind of adding into this virtual care, connected care buckets, which has definitely opened up some new pathways for reimbursement. And also they've continued to acknowledge per the law that some disease states can have amended originating sites, which has also been one of the sticking points. So most notably with the passage of the Support Act last year, as Dean alluded to, for purposes of opiate treatment, your home can be an originating site. So, in addition to reimbursement, there are those other policy pieces that also kind of factor into the ability and the efficacy and the user-friendly nature, one might say, of offering telehealth. So it's something that I know when we just submitted our comments recently on the physician fee schedule, we continued to point to, and will continue to point to, as these rules continue to evolve and as we start to again see the development of new codes and the acknowledgement of new codes. And we also have to tread lightly because, we want CMS to acknowledge telehealth, but as Tom alluded to under 1834M, there are boundaries that have been put up, but if they are able to skirt around the edges and find some creative authorities that allow for reimbursement of services that may traditionally fall into those buckets, but don't necessarily have to be called, we want to be really careful about not asking them to be overly prescriptive in their definition of these services for reimbursement purposes. So we have come, a long way. I think we cited a statistic that I don't have anything new. I think it dates back to like 2016, but there's so little reimbursement in the Medicare space. There was something like a 79% increase between 2014 and 2016, and that only equated to something like $27 million in Medicare reimbursement. So if you're looking at, 670 plus billion in reimbursement during that time, the 27 million is essentially a drop in the bucket for telehealth services. So yes, those are, from 2014 to 2016. And as we've alluded to, we've come a long way in 5 years. So even those last 2.5 years, we've probably had significant gains, but it just is another kind of data point of there's a lot of great progress, and in the private payer space, there's a little bit more going on. But in the Medicare reimbursed space, we're still just very much scratching the surface of what's possible.
So kind of picking up, Leslie, on what you're talking about, some of the creativity being utilized by CMS, what about the innovation models that are out there where maybe you're not necessarily focused on code by code reimbursement, since a lot of those programs are moving into value-based care? Are those programs doing anything to help incorporate telehealth as a more comprehensive suite of services, where because you're getting either a bundle payment or a set amount per member or per beneficiary, you don't necessarily have to worry about a specific reimbursement value tied to the particular service?
I can start and others can jump in. So, this is something we've time after time pointed to CMMI because they do have a different level of authority and the ability to leverage their demos to be able to test some things out that could ultimately, prove valuable in making the case to CBO and to the CMS actuary. But we just commented, we joined a stakeholder letter that looked at some of the bundles and pointed to the value, and whether it's oncology, ESRD, some of the other bundles, and saying, in these scenarios, there is great value in looking at connected care, virtual care, telehealth, and so they should be taken into account. So I don't think it's been as robust as is possible, and that's why the industry is saying, take a look at these for the purposes of bundled payments. But I don't know if Dean or Tom wants to add. But you're right, that is kind of the alternative when you're looking at something that's less traditional in terms of reimbursement models. There's a little bit more flexibility.
Yeah, Leslie, it's part of the part of our responses and have been to push for CMMI as Adam Bowler was first coming into the Trump administration. He was, they wanted to know from industry, what is CMMI been doing, and what could we be doing better? And we too really let our members' voices be heard on the fact that more telehealth embedded into the innovation models. The other piece is that from a PCORI perspective, the funding that it runs out this year, but we've been pretty vocal with them the last several years in terms of thinking about other ways to leverage technology and telehealth. When PCORI gets reauthorized later this year, I guess in the next few weeks, we anticipate that there will be more of an emphasis on leveraging all levels of technology and to include telehealth. So those are two active areas that I think the community really needs to be more vocal in, with both the innovation models at CMMI and then the work that PCORI is doing on behalf of the government.
Yeah, and I'll just wrap up by saying, the CBO concern, or even a paradox, if you want to call it that virtual health, telehealth, is going to drive up healthcare costs by increasing access to healthcare services. Again, clinician in the clinical world, there's a lot of shoulder shrugging about that. Access is a good thing. We want our patients to have access. That stated, we're all taxpayers and we get it. We want to be good stewards of a limited resource. So I think all of that underscores the fact that we need outcomes. We need outcomes data. We need clinical outcome data showing that this increased access from virtual health improves healthcare outcomes. And we've got a lot of studies out there on virtual medicine, telehealth being published every day. Most of them currently focus on processes. You can increase access to diabetic care. You can increase time to stroke care through telemedicine, through virtual health. But does that have long-term outcome impact on population health, et cetera? And that's what's really lacking currently. And once we get that data, I'm optimistic it will definitely show there's a significant benefit of virtual health. And then I think CBO and everyone else will fall in line.
So one of the things that, from a Chime perspective, we've been looking at legislatively is the fact that we know even within the federal government, there's a lot of telehealth going on, right? The DOD and VA, as Dean can speak to, is doing a lot of telehealth and has been doing telehealth for many, many years. We know there are many other grant programs that are funded by HRSA or SAMHSA or others within the federal government that have findings. But it's not clear that those findings from whether it be the federally administered telehealth programs or even the grant programs are trickling back up and then shared across the industry as folks are looking at what disease states are having the best outcomes, or where are costs being saved, or maybe this was we thought it was going to be great in this particular community and in rural America, but no, we were wrong. It's resulting in overutilization or unhappy patients. So we need to do a better job as an industry, even leveraging the things that we're funding as taxpayers and making sure that we are disseminating those findings back out. And I think, one of the things that we've looked at is the fact that there really isn't a central point within the federal government. Similar to EHRs, we have ONC, but there doesn't seem to be one central point or one central leader on telehealth that could be, whether it's an aggregator of opportunities, whether it's an aggregator of resources, if folks have technical questions. HRSA has their telehealth advancement centers across the country, but kind of per the point of needing to make the case and needing to demonstrate the value and the outcome improvement, how could we coordinate better across the federal government and make sure that we can get to those resources and help ourselves essentially make the case? So we're working with folks on Capitol Hill on how we can maybe improve coordination. There's a lot of conversations relative to broadband coordination right now. So we're kind of looking at that and seeing how that might translate to something like telehealth. It's not popular to create a new office or a new entity within the federal government, completely acknowledge that. But if there's a better way that we can coordinate and make sure that we are getting those lessons learned, particularly from the federally funded projects, I think that would go a really long way in our efforts to move this ball forward.
Find a way to amplify, not just the HRSA grantees learning from each other, but how does the HHS secretary and his four pillars, how does he fit some of these lessons learned so we amplify the messaging? I love that.
Yeah, and I amplify what Leslie said too. The VA is a leader in telemedicine, telehealth, and I know GlobalMed, our software, hardware is in all of the VA centers and CBOCs countrywide. So they're using it. They're using the technology. They have the experience. They've got the data, and it needs to get shared at some point. I do believe, and Leslie and or Tom, you may know, I believe there's a bill in the Senate just got introduced to create a national telehealth center. I believe it's called the Telehealth Across State Lines Act, and I think it's fairly early in its infancy, if you will. But be curious to see where that goes, and that might again it might address some of these barriers.
So it seems like all three of you have focused a lot on discussing initiatives at the federal level, and maybe to the point of there hasn't been a champion or at least one centralized champion. what role do the states have, and are any of the states experimenting with expanded coverage or utilization of telehealth? And Dean, why don't we start with you if you have any examples you can provide there?
Yeah, states are certainly using telemedicine, or at least legislating for it to certain levels on the Medicaid level. But it's really a mixed bag. We have 50 states and 51 different regulations and laws pertaining to how telemedicine is used. California tends to be pretty progressive in terms of what they're doing with telemedicine. Other states less so, but we get into barriers there in terms of licensing and credentialing, et cetera, of providers, parity laws, et cetera, that really hinder the adoption of the technology.
I would just say ditto to what Dean said. I mean, the fact that you've got 50 states, some are prioritizing different disease states, some are leveraging their Medicaid program in different ways. And, in some cases, there are states that are far and beyond in terms of what they're willing to reimburse for and what they're giving providers credit for than the federal government. So there are definitely some early adopters or first movers that I think we could definitely learn from at the federal level. But it's so inconsistent, and there are bits and pieces of different bills and different priorities, but it's very state specific. But absolutely echo what Dean said.
Yeah, I had the pleasure of being out in Colorado with our Colorado chapter in the last 12 months, and one of the guest speakers was a gentleman who had received telemedicine, not just a consult, but actually he was on the work site not too far from downtown Denver, his construction work site, and on Friday, his team had gone through the process of, what happens if there's an injury, and they knew the route to, if you happen to, if the ambulance can't get there, throw somebody in the truck and then drive them over to the local hospital. And this was the following Monday. He's sitting there, and all of a sudden, one side of his face is going numb, and he's slurring his words. Team knew exactly what they do. They threw him in the truck, drove around 3 or 4 blocks, got him to the local hospital. Unfortunately, and fortunately for the individual, there was it was a community health center, but they had an agreement, a telehealth agreement with a tertiary care facility not too far away. They were able to light up the telehealth, the video, and the provider was able to, at the tertiary care facility, was able to interact with him and get him on the life-saving medication, and he was back at work 3 weeks later and as a guest speaker at this event because changes in Colorado law. So to Leslie and Dean's point, unfortunately, each state has a little different approach to it, and I would say that one of the areas that we're real concerned about is several states that have been innovative on telehealth, if in tighter Medicaid, tighter budgetary times, are starting to pull back on some of the ancillary, what they're identifying as ancillary or extra services. And so even in the state of Illinois, we're starting to see a bit of a pullback on telehealth reimbursements at the state Medicaid program. So it's leveraging those positive examples. It's working with we've been working with the states and with our chapters to update their health IT roadmaps with a vision towards telehealth and public health infrastructure being part of a smarter approach to care delivery. And then what it really is needs the involvement of all of us and the folks at the National Governors Association and National Conference of State Legislatures. Their healthcare teams have been trying to create with input from our community, trying to create ways to standardize legislation so that you can start to address some of the barriers at the state level, so that there's an example of Colorado Children's recent Davies Award winner just in the last this time last year. They're the tertiary care facility for 5 states, and there's a lot that can be done as a result of the changes in Colorado law on telehealth. But some of the neighboring states have challenges with respect to what their state laws allow, and therefore harmonizing just within that care system, being able to harmonize those 5 state requirements is a big barrier and an opportunity for all of us. So working within the National Conference of State Legislatures, working with the National Governors Association, because they want to provide access, they want to improve the care delivery for their citizenry, but dealing with varying, whether it's telecommunication law changes from state to state or privacy requirements, all of that is really an opportunity for all of us.
So thinking about some of those barriers and, on the state level, I think as all 3 of you are describing of, I don't know if discrepancies is the right word, or a desire for a unique set of rules in each state, is there any possibility or likelihood of getting some type of a national standard? Tom, I know you were just talking about, the National Conference of State Legislators, and I think I can remember if you or someone else was talking about the governance, the National Governance Council is, trying to do something. But, it also feels like whenever you're talking about all these different licensed professionals, each state still likes to guard, what it views as its territory and have an individual license. So with this recognized barrier, is there, any justified hope that, the barrier could either be removed or at least lowered, so that it is, it facilitates the quicker, or an easier path to utilization of telehealth? And Tom, I'll start with you, since I was kind of picking up on a bunch of what you were just mentioning.
Absolutely. One of the areas that has been the coalition that we're part of, and Leslie is part of as well, has been very active in starting to work on provider credentialing, and I think we may be up to 14 states that have agreed to change and allow for changes in their credentialing protocols to allow providers from other parts of the country, to take advantage of telehealth, so that their providers can provide, can go across state lines and provide care to other places, and opening the door for others, for their citizenry to have access to providers from other jurisdictions. So what was once very much a barrier is starting to be normalized, and the barrier is being torn down, if you will, because of organizations like the American Medical Association and American Nursing Association are absolutely part of this coalition, and have worked through, or working through with their state representatives, if you will, on why it's beneficial for improving care delivery, and that it's not as much of a threat for their providers' livelihoods as may have been thought to be the case in the past.
Yeah, I jump in on that to reference what Tom is stating. The big issue for clinicians is the medical licensing, which of course, again, is controlled on the state level. And, you have to be licensed as a provider. You have to be licensed in the state where the patient is. And we've got 50 states in the District of Columbia. And that means if you're really going to do nationwide, telemedicine as a provider, you have to be licensed in 51 places. Well, getting a medical license is not an easy task. There's, a myriad of forms you have to fill out. It's expensive, typically, $500 an application. One one way of addressing that, and I think 29 states have currently signed on, is the Interstate Medical Licensure Compact. And that allows you to be licensed in a primary state, and then your licensing is kind of reciprocated, if you will, by other states that are in that compact. And again, there's 29 states in DC that are currently participating. It's still a fairly expensive process because in addition to your state licensing, you also have to pay for this additional service, if you will. But nonetheless, it does help break down some of the barriers. That stated, flip side of that coin is there's still 21 states that aren't a member of it. And in talking to some of my clinician colleagues who are doing high-level virtual health, some of them are licensed in 10, 15, 20 states. And that is no small task of maintaining that. Very onerous, very expensive, and again, represents a significant barrier to virtual health adoption.
And to build on that, there's been a few different attempts on Capitol Hill to try to address this. It becomes very political very quickly. It's been a few Congresses now, I believe, since there was one addressing kind of broader medical providers, but the conversation of late focused on VA providers. So we saw Congress act, and then we saw the VA act through rulemaking last year, clarifying that, you know, their providers can treat patients across state lines. So we're very much looking to them as a model, and we were supportive of that legislative effort and that rulemaking because, you know, if we can show lessons learned through that, through the work of the VA and their patients, hopefully we could, you know, leverage that to expand this conversation and make the case. And it is something, you know, Chime often falls in the camp of we are equal opportunity telehealth. We want more reimbursement. We want technology to be more standardized. We want integration in the EHR, but we also, you know that licensure is an issue and are very supportive of all of the different attempts to address this licensure issue. So it's front and center. We haven't seen it tackled recently, as recently as we had in prior Congresses, but it's definitely something that has, at least in the past, been on congressional radars in terms of what could their fix be for cross-state issues.
Sure, and kind of building off of a lot of the organizational level efforts that Leslie and Tom, the two of you have been talking about, could commercial entities be doing more to make this more of a business case? Because arguably it's great when you have the organizations like Chime and HIMSS gathering many voices together, and it kind of creates a funnel. But at the same time, arguably there's the impact that can be brought by a business in a particular member of Congress's district saying this is impacting our ability to operate. Picking up on some of the things that Dean was saying about the cost and the time, I've represented some physicians who are looking to be employed by a telemedicine company, and the company will help them get the licensure everywhere, but it is recognized that that's costly and that there could be like a penalty if the physician left employment in a certain amount of time where they'd have to reimburse all that cost, which arguably is a disincentive. So I guess to bring it all the way back around, is there more that businesses operating in this space could be doing with individual voices to help on the advocacy front?
I mean, we even saw this week kind of Amazon enter this space, right? So I think we're going to see some of the large industry movers, whether they're traditionally healthcare or not. We're also seeing, the services emerge of more direct-to-consumer telehealth or remote monitoring, virtual care, virtual coaching, applied health signals. So I think, yes, to your point of can an individual entity within a congressional district or state, can they, point to the potential of this and the need to act? I think absolutely. But I think, it's not just going to be the traditional site of service that's going to move this conversation. And I know for me personally, I chose my primary care practice because they offer a 24/7 telehealth platform that I can, sit at home if I am feeling lousy and read them my temperature and get my Tamiflu. So, I think there's that also level of whether it's generational or awareness of the industry, but I think there is that business case that's growing in the private payer space that is allowing them to, look at nurse lines and telehealth around the clock, leveraging other, non-traditional service providers. So I don't know, Tom, if you want to jump in on that too.
No, I think you're right, Leslie, and it goes to employers are looking for ways to reduce the overall healthcare costs while increasing the access to care for their employees. So employers are traditionally that have been involved in paying attention to benefits are absolutely more involved in the discussion of telehealth services available to their employees. I would also say that the advent of a nurse advice line is finally the technology is catching up to that type of idea. A former employer where I worked, we were pushing nurse advice lines as part of a effort with for a TRICARE program that we were running, and it was hit and miss at the time. You fast forward 15 years, and the technology is such, and the exposure of the consumer to the possibility of not having to feel just well enough to drive into a facility, but actually using your phone, in the internet connection. I think it's a nice convergence of the patient and the employee is expecting more. The employer is looking for greater ways of access for their employees, as well as ways to rein in some of the healthcare costs. So I think you're absolutely right, Leslie.
So it seems like both of you are, discussing. I keep hearing both of you say employer. So obviously, so companies offering a telehealth or telemedicine-based benefit to their employees. Is that something that is occurring with more frequency? And I guess maybe connected to that, I think either or both of you also mentioned, commercial plan design, which seems to be adding a telehealth benefit in more frequently as well, which, maybe it's two sides of that same coin, because if the employers are asking for it, who better to kind of facilitate the access than the plan? So, kind of what are the changes that are being seen from that commercial perspective? And, if we're seeing positive changes, could that be a model for Medicare or Medicaid to replicate?
Yeah, and as we talk to our members, some of them are saying, you think of like a UPMC that is blurring the lines between a provider and an insurer, and they're leveraging the technologies that they've either created themselves or brought in from vendors. Similarly, talking to some folks at some of the insurance companies who are saying that, we're not just providing insurance, we're now they think of the mergers, some of the mergers that are taking place of getting involved in CVS and Aetna's, for example. It's absolutely a blurring of the lines of the roles, traditional roles in healthcare. So those organizations are looking for ways to leverage telehealth, so that whether it's getting to the minute clinic or having access to the provider at the minute clinic when you're 5 minutes, half hour, whatever away, that is becoming more prevalent. One of the things that when I was working at the Pentagon, I had the luxury of every Monday morning, this woman would call me. She was the wife of a retired E9, and she would talk about how just to get certain services done on their limited budget, she had to drive 400 miles each way to the military treatment facility. And that is all pre-iPhone, a lot of telehealth services. Now you have the opportunity, through the TRICARE program, through any of these government programs, any of the insurance programs. Really, there's more access to taking the patient's situation into account and leveraging technology so that the Marys from Nebraska doesn't have to drive all the way to North Chicago 400 miles in each direction to receive certain care. It's really the case, I think, as we're looking at technology's involvement in healthcare transformation. Telehealth is absolutely center stage of what the art of the possible for me.
So, and even adding to that, I mean, we've said in our comments, technology has advanced to the point where technology isn't the problem, right? It's a lot of the policy pieces that surround this conversation that are impeding. But back to your point about, you know, what different employers or different private payers might be doing, we even have health systems that are using telehealth as a new commercial service. So I'm thinking of a major health system in a major metropolitan area that has put kiosks in one of the large pharmacy chains in their city. And anyone can walk up to these kiosks and see a professional in the ED. And so you pay your upfront copay, but you are immediately seeing, an ED physician at one of the departments without having to walk in. And these are all throughout this area. And they're, you know, making money off of that initial investment from the patient when they present at the kiosk. So, you know, we're seeing those sorts of things start to pop up, not only as, you know, payers are doing different things or employers are doing different things, like getting their employees coaches or enabling remote monitoring because they're seeing the return on investment. But we're also seeing, you know, health systems be more creative about, hey, if we start a telehealth second opinion program and charge everyone $200 for a second opinion, that's money in their pocket. That doesn't have to go through insurers. So I think, you know, you're seeing folks across the telehealth ecosystem think pretty creatively on how you can leverage it. And, you know, what's interesting and ironic about this, right, is we're seeing employers recognize that there is a value in investing in coaching or remote or telehealth services, but we're still seeing the federal government lagging. So hopefully we can start seeing, you know, the translation of outcomes and improvements and happiness amongst employees and patients ultimately translated to federal policymaking.
Sure. And actually, Leslie, I'd like to pick up on a point that, and this wasn't even, you know, well, one, I think, you know, everything that you and Tom were just describing is a lot of food for thought, but I want to kind of build off of a comment that you had about technology not being necessarily an issue anymore. You know, even as we've seen during this program with first me and then Dr. Smith having technology-based issues, you know, are we maybe overstating that technology access isn't part of the issue for telehealth? You know, and I'm thinking not, you know, and I know at least I'm in a greater major metropolitan area. Dean, I can't remember where you are, but thinking about rural areas, you know, or even in less affluent areas of urban areas where people might not have access or the ability to kind of adopt the newest technology, you know, what are some of the issues around the technology itself in terms of being able to access telehealth? And Dean, since we're very happy to have you back with us, I'll let you kick it off with that one.
Yeah, I'll jump in. Apologies. I actually happen to be, well, although I'm based in Washington, D.C., I happen to be out in the mountains of Oregon, where my family has a little farm and just getting it ready for winter. We don't have broadband where I'm at. I actually connect to the internet via a radio system that shoots signals to a nearby mountain and then connects into the internet that way. But I don't have broadband. It works pretty good when it works. Obviously, when it doesn't work, it doesn't work. And so I actually, with Redundancy, I jumped onto my cell phone hotspot and able to connect back in that way. And I think that underscores what you have to think of as you set up a virtual health program. And I'm speaking about, you know, the clinical world, the technical world, and that is redundancy. Because even in metropolitan areas, you know, internet goes down, and when you're in the middle of seeing a patient with a life-threatening illness, a stroke, you can't, you know, you can't afford downtime. So you have to build in redundancy into the platforms, and hardwire is great again when it works, but you have to think of, okay, what other technologies can you tap into, satellite, cellular networks, etc. Looking ahead, networks are getting better and better and better all the time, and we've got 5G just getting deployed in the U.S. There's low Earth satellite Wi-Fi coming down the pike, a host of other technologies that will be available in the coming years. And as we look at deploying telemedicine, we have to think of those as really will be a backbone of what we're trying to do with this technology.
Yep, that's exactly right. So when I'm thinking of, I pick up this device, right, and I see my doctor within whatever a 5-minute wait time. We're even seeing more integration of telehealth platforms into EHRs, which is something that we were really concerned about if you're starting to have, yet another interoperability challenge. But Dean hit the nail on the head. Connectivity is one of the biggest barriers, and absolutely probably is the leading technical barrier for patients. And, both from the broadband perspective, so Chime has been enthusiastic about the fact that the FCC is looking at extending broadband availability through, USF and doubling the funds of it, or almost doubling the funds available. So we're very supportive of that and recognition. We've also heard, and Dean touched on 5G, the biggest use case it seems for 5G in healthcare is remote, the fact that you can upload better quality faster and start to alleviate some of the, where there are broadband shortages. But I do want to point out one other thing. We were talking to one of our pediatric CIOs in a major metropolitan area, and they have actually experienced issues with families that have limited data. So if you're on a limited data plan, but your child's implant follow-up is determined by your ability to participate in virtual care, you're going to end up leaving out sections of the population if they do have, cost challenges with, data plans. So, it's not just broadband and, 5G. We're enthusiastic about the potential of 5G to really move this conversation forward, but we also have some lingering issues that could end up impacting some socioeconomic classes if also not addressed. So absolutely say yes to what Dean has said.
And what's nice is, just in the last, 30 days, we had a comment period for low income, the FCC looking at the issue of the impact of promoting telehealth within low income families and communities. So we too support the fact that they're asking the question, and it's funding, it's making sure that just when we think that the digital divide has been closed, there's another leap forward in technology, and the haves outsprint the have-nots. So shrinking the amount of time that it takes for all communities to have access, or just really having a policy that moves every community forward synchronously, if you will.
So, and Tom, sorry, Dean, go ahead, and then I'll have a follow-up question.
Yeah, just one real quick comment, and that is that broadband access to broadband actually correlates with healthcare to some degree. And if you look at map overlays of where you have broadband and where you don't, and rates of obesity and complications of diabetes, there's a remarkable synergy, if you will, between those. Not saying that's causation, but there's certainly strong correlation there.
That's actually a very interesting fact. It's I suspect something that not a lot of people would have been looking for, and certainly not aware of, Dean. But and actually, kind of using that, I want to go back to a comment that Tom, you made, and Leslie, I think you made in passing, which is FCC work in terms of promoting access. Would you be able to give a little bit more background in terms of what that is? Because I'm not sure many people might realize the role the FCC has in promoting rural access to broadband or other communication.
Absolutely. The Rural Health Care Fund has been around, I think, since the late 90s, and it's you look at whether it's your cable bill or your phone bill, there's been a tax to help level the playing field for underserved communities in particular, to be able to get the final mile, if you will, of broadband to first dial up and then broadband to those communities. And as we've over the last 3 years, let's just go back 5 years ago, there was a big push for the FCC to double the amount of money in the fund, because for the first 7 or 8 years of the program, there were too many restrictions, and therefore the money was being turned back to the Treasury. So it finally, when meaningful use comes along and communities get more coordinated and HIEs, the health information exchanges, are more coordinated, there was suddenly not enough money in the fund to meet all of the demand as technology increased and as communities got more organized. So what the FCC did about just shy of 2 years ago was increase the amount of money on a short-term basis to allow for more communities to be able to close the gap and finish, make sure broadband gets all the way, meets the final mile for particularly for underserved communities, whether they're rural and underserved or in cities and underserved. So this next step by the FCC is in this notice of proposed rulemaking is, all right, we're making more progress in terms of getting the wires and boxes in place. What's the next level of responsibility from an FCC perspective to make sure that, particularly in low-income communities, we continue to anticipate and build infrastructure that supports those communities? So just in the last, I guess it was 90 days ago, they came out with a proposed rule on, this is how we think we could meet some requirements. What do you, the community, think? What's your reaction? And so I know many organizations, including HIMSS and our partners at the Personal Connected Health Alliance, responded with our thoughts on where the FCC is and where they need to be, really make sure that all communities have a level playing field.
Yeah, no, thank you for helping to provide a little bit more color around that. And as we're already starting to get I think fairly close to the end of our panel, what I'd like to do is turn over to each of you in turn to provide a conclusory thought or some concluding thoughts, because I suspect that there's probably many ideas that each of you would still like to put out there. So kind of the setup that I'll use for it is, we've been talking a lot today about the past and the current status of virtual care and telemedicine. So, building off of that discussion, what I'd like to have each of you answer is, what do you think will be happening in the next 1 to 2 years? And I'm purposely going for a relatively short time period forward, because I think there will be a significant amount of change within that period, and it would probably be hard to predict too much past that. So Leslie, let's start with you.
Great. Thank you. Thanks for allowing me to be part of the discussion. And, it's something that we have seen our members prioritize more and more year over year. We've seen the market shift and new players in the market emerge as we kind of see the healthcare, traditional healthcare dynamic really flipped on its head through the emergence of new players in the space. So, I think we'll see Congress, pay more attention. We're anxiously awaiting the reintroduction or introduction of the new Connect for Health Act. We're waiting for another version of 21st Century Cures, and kind of acknowledging that there's a commitment to health IT to transform care. So I think we're going to start to see more of that, as well as just the overall maturation of telehealth policy, in the sense that CMS seems to continue, under their authority, to acknowledge where their limitations are, and continue to kind of do what little they can. But it's going to be really incumbent on us as the stakeholders, as the users, as my members, as the leaders within their institutions, that are making the business case, to be able to articulate what the value add and the outcomes improvements truly are. So I think we'll continue to see on the policy side those incremental gains. But I think the good news is that industry seems to, unlike in some cases, actually be surpassing us. So I think keeping an eye on what's going on with the private payers, with the employers, I think will, shed light on what we can really expect from this conversation moving forward.
Thank you, Leslie. Tom?
Sure, and Leslie nailed it. So thank you again for allowing me to be on in this discussion. I think that as we look at remote patient monitoring, we'll have a continued uptick in the number of organizations that leverage that from a provider perspective, and as patients become even more comfortable with technologies in their home that can help them make smarter decisions. I see a continued uptick in remote patient monitoring services being leveraged, and then evidence-based information gets back to us from whether it's the pilot on ESRD or telestroke. We'll begin to be able to tackle the obstacle that is the CBO scoring on telehealth here in the U.S. And finally, I would say that from a standards perspective, the international community is really looking at FHIR, to help with open APIs and improving access to care. A coupling of one effort that HIMSS has underway is a coupling of the FHIR standard with our continuous standard that's been in place for over a decade. That is going to have an impact on the technologists and the types of solutions that they can bring to the remote patient monitoring initiative.
All right, thank you. And Dean, you're our closer today.
Okay, well, also want to extend my thanks for asking me to participate. I think it's been a really interesting conversation. Just to amplify what Leslie and Tom have said, increased adoption and usage of telehealth, I think is going to be a given. Remote patient monitoring, et cetera. We've talked about how improving reimbursement and licensing, credentialing regulations will help that effort. A couple other things, though, I think are going to drive it forward, and one is certainly going to be the improving just technology itself. Telehealth hardware and software is getting better. EHR integrations through FHIR, et cetera, improving communication networks, and all of that is going to work in concert to drive adoption forward. And then last but not least is just we're going to get data. We're going to get outcomes data, cost benefit analytics that again I think will help the whole conversation with CBO and other regulators. So thank you again.
Yeah, no, thank you, everybody, and thank you for making this a very successful and I think first panel on telemedicine, and also thank you to everyone for bearing through all the technological complications that we had, which it seems fitting given the focus of our conversation today. So thank you again, and we'll look forward to seeing all of you on the next panel.
We'll file that under irony. I want to thank you all again. Obviously, Matt, Dr. Smith, Tom, Leslie, great conversation for our first virtual panel discussion on this critical topic. Obviously, based on what you guys have said, I imagine that we'll have this again next year. So put that on your calendar. Thank you all, of course, to our attendees, and we appreciate your time, and we'll look forward to seeing you on the next event. This is Carol Flagg. I'm signing off.